2/6 video, Bilateral Vestibulopathy, Pathophysiology, VOR failure and sensory substitution, Vestibular physician. Welcome back, everyone. Look, if you're a neuro-otologist, an advanced ENT trainee, or a senior vestibular physiotherapist, you are exactly in the right place. In this explainer, we're really going to unpack the deep mechanics behind what is honestly one of the most debilitating, yet somehow still under-recognized conditions in vestibular medicine.
Our main goal today is to map out the exact pathophysiological cascade of bilateral vestibulopathy, or BVP. We're not just looking at surface-level symptoms here. We are going deep into the underlying structural and functional collapse. We really want to understand precisely how a bilateral loss of afferent input essentially forces the central nervous system to rewire itself, and crucially, why the brain's attempts to substitute for that loss ultimately fall short. To kick things off, let's talk about the clinical paradox of BVP. Now, at low head velocities, your patients might actually show pretty adequate compensation, right? They look relatively stable just sitting there in your exam room. But shift to high head velocities, think walking, running, or just navigating a normal set of stairs, and you literally witness a complete systemic failure. The patient experiences just overwhelming unsteadiness. So why does this happen? Well, to figure that out, we have to do a deep dive into the absolute mechanics of their core deficit. And that brings us to the failure of the final common pathway, the vestibulo-ocular reflex, or VOR. The VOR is honestly a high-speed marvel of human neurobiology. Its entire job is to generate compensatory eye movements that are perfectly equal and totally opposite to head rotation, and it does this at a staggering latency of under 10 milliseconds. I mean, that's incredibly fast. This extreme speed and precision is exactly what prevents retinal slip and keeps our visual field stable when we move. But in BVVP, this reflex, it's completely abolished on both sides. So this builds up to a pretty catastrophic problem. Unlike a unilateral vestibular loss, where, the intact contralateral labyrinth can kind of step up and the central nervous system recalibrates to compensate, bilateral failure is a whole different ballgame. There is absolutely zero residual vestibular drive. The brain literally can't use central recalibration. Instead, it gets backed into a corner and forced into a drastic, fundamentally flawed workaround. It has to rely completely on non-vestibular sensory substitution. In clinical practice, this failure is just unmistakable when you look at a video head impulse test, or VHIT. You'll notice the severely reduced bilateral horizontal VOR gain, falling way below that 0.6 diagnostic threshold. And because that smooth reflex has just gone, you see these massive, overt corrective catch-up saccades scattered all across the velocity trace. The eyes are literally jumping to catch up to the head movement because the underlying reflexive drive is just completely broken. To handle this massive sensory void, the brain initiates a process called sensory reweighting. Basically, vision and proprioception get heavily upweighted to try and keep the patient upright. But here's the catch. These substitute systems have hard limits. Vision, it's totally inadequate in low light. Proprioception, it fails on compliant or uneven surfaces, think thick carpet or walking on grass. And even the cervico-ocular and optokinetic reflexes, which try their best to partially substitute for the VOR, they just completely fail the second head velocities increase. Which brings us to a very critical threshold. 2 Hertz. This number is absolutely crucial because it represents the hard physiological limit of visual sensory substitution. With slow head movements, sure, the visual system might just be fast enough to stabilize gaze. But once head movement velocities exceed roughly 2 Hertz, which, by the way, is exactly what naturally happens during normal walking or riding in a vehicle, the visual system simply cannot process information fast enough to eliminate that retinal slip. Now, what does exceeding that 2 Hertz threshold actually look like for your patient in the real world? Contrast the clear, stable world of normal vision with the harsh reality of velocity-dependent oscillopsia. Imagine walking down a supermarket aisle and experiencing this continuous, disorienting visual blurring and bouncing with literally every single footstep you take. This is the absolute hallmark symptom of BVP. It is profoundly disorienting, and it's all because that under 10 millisecond VOR is gone, and the visual substitute just isn't nearly fast enough to keep up. To truly grasp BVP, we need to briefly step down to the molecular level. Like, what is actually destroying this apparatus? Well, aminoglycoside antibiotics like gentamicin are a huge culprit here. They destroy type 1 and 2 hair cells via oxidative stress. Then you've got cisplatin and platinum-based chemotherapies, which cause a very similar cumulative cochleovestibular toxicity. Add to that autoimmune inner ear diseases that specifically target endolabyrinthine structures, plus genetic causes like COCH mutations, also known as DFNA9, which trigger progressive fibrocyte degeneration.
But here's the thing, the destruction doesn't just stay isolated in the inner ear. It actually climbs right up into the cortex. And this number should really grab your attention. 17 to 42. In chronic bilateral vestibulopathy, we see a shocking 17 to 42% reduction in hippocampal volume. This atrophy is directly proportional to the severity of the bilateral vestibular loss. The lack of sensory input is literally shrinking a core structural component of the patient's brain. It's wild.
So as you can see, bilateral vestibulopathy is far more than just a motor reflex deficit. It is a profound driver of cognitive and spatial memory impairment. Because of that bilateral deafferation and the resulting hippocampal atrophy, these patients experience severe spatial disorientation. Their place self-firing is impaired. They have massive difficulties navigating once familiar environments, and they suffer from very real spatial memory loss. And look, while vestibular rehabilitation therapy, or VRT, is definitely our frontline tool to optimize that non-vestibular sensory substitution, we have to recognize that it only partially mitigates these deep cortical and cognitive consequences.
All right, let's wrap up this pretty complex cascade. The crucial points to take away from this explainer are threefold. First up, bilateral VOR gain reduction is the primary core deficit driving the entire condition. Second, the brain's attempt at sensory substitution is inherently incomplete. It specifically fails at high head velocities above that 2 Hz threshold. And third, we can never forget the cortex. Hippocampal atrophy is a severe non-motor consequence that genuinely impairs your patient's cognition and spatial memory.
Now that you understand the precise mechanism of this systemic failure, you're perfectly primed for the next step in our series. In video 3, we cover clinical features, the full etiology table, and the Barney diagnostic criteria. We'll be taking everything we learned today and applying it directly to your bedside and laboratory assessments. But before we go, I really want you to ask yourself, how many patients sitting in your clinic right now might be silently experiencing this progressive cortical atrophy, currently disguised as just simple unsteadiness? It's definitely a question worth investigating. Visit AustralianDizzinessClinics.com for the full literature review and clinical resources.